Welcome to this conversation series where we hope to interview people in a variety of roles within the implementation science community. We're starting with Professor David Currow, who many of you already know. So David, welcome. Could you please introduce yourself?
I'm David Currow. I'm the Chief Cancer Officer of New South Wales and the Chief Executive Officer of the Cancer Institute New South Wales. The Cancer Institute New South Wales is the government's cancer control agency, charged with reducing the incidence of cancer, improving survival for people who are diagnosed with cancer, and improving their quality of life.
So look, implementation science is clearly being talked about an awful lot everywhere at the moment. And I think the Cancer Institute's actually led some of that, or much of that, a lot of that conversation in our state. So, I mean, can you reflect on what the vision and the priorities are for implementation within the Cancer Institute?
Clearly, it's exciting that we face so much new knowledge in cancer. Every week, new treatments, variations to old treatments, and that process is wonderful, but we need to make sure that it's getting to the coalface. And that requires us to work with patients, to work with primary care, to work with tertiary care to ensure that that's happening. It's not a passive process. We need active implementation processes if we're going to take that forward. We've got super early adopters in clinical practice through to people who are in established practice and are unlikely to change unless you and I work with them very closely. It's that spectrum that we need to address. And if we can do that successfully, we will ensure that cancer outcomes continue to improve more rapidly. But there's a collateral benefit here. That collateral benefit relates to the fact that if we get it right in cancer, other clinical disciplines are going to benefit from this. And so our vision is to ensure that as new knowledge appears, that we are working with clinicians and the community more broadly to ensure that there is adequate uptake. At the same time, the challenge that that brings to us is that we will need to look at areas where we disinvest, where we stop doing things that we have done perhaps for years or decades because something better is in their place. That's a big challenge. Again, we're creatures of habit. How do we systematically go about the science of doing that as effectively and as quickly as possible?
Could you reflect on what are the components of successful implementation? So there's lots of people trying implementation, but what really makes it work? What kind of resources do you need? How do you actually apply that into practice?
When we think about implementation science, we need to think about a pipeline that involves the researcher who's doing the research that we want to implement. How do they ensure that their research is as practice and policy ready as possible? How do we think about our target audience as we work with health professionals, nurses, allied health practitioners, medical practitioners, and take that forward? And so implementation science will require bespoke solutions for each of those audiences. As we think about primary care, we put so much pressure on primary care to be across this plethora of new knowledge. How do we make it easy for them in day-to-day clinical practice to know how to access the new knowledge that is relevant to them and ensure people are finding their way through the health system as effectively as possible? These are real challenges that are there with us every day, not just in cancer, but in every clinical discipline. Cancer, however, is such a great example because as we think about cancer, we've got this real challenge that in surgical oncology, medical oncology, radiation oncology, this rapid expansion of knowledge. No one practitioner can ever hope to be up to date with all of that. And even as we synthesize that through systematic reviews and meta-analyses, no one practitioner can hope to be up to date. So how do we create both a research workforce for developing new knowledge in implementation science and the implementation workforce to actually get out there and make those changes? As we've seen from reviews, such as the Cochrane reviews on practice change, there are a small number of things that have been shown to change the beliefs and behaviours of established practitioners. I want to see that science expand so that there are more tools and the greater ability to adapt that to individual practitioners' beliefs and behaviours.
Thank you. So when you talk about implementation, one of the huge challenges for me has always been, how do you sustain that change? So once you've implemented something, how does that remain in the system, if you like, and be part of that system in an ongoing way, particularly when we actually fund implementation sciences as small kind of 1 to 3 year projects often?
Sustainable projects are going to be funded because the community sees benefit. We have to show the success of good implementation science, and the community will invest. It will create positions in the long term, not just for the scientists developing that new knowledge, but for implementation practitioners, people who will change the beliefs and behaviours of individual practitioners, of groups of practitioners, of whole health systems. As we see that come to fruition, the community is going to reach deep into its pockets to ensure that that is taken forward. But we have to demonstrate success. And we have successes across the system, but they're small and they're new. We've got to get out there and have this discussion with the community at large.
One of the things I've noticed in implementation science over the last 10 years that I've been involved in, when we started, there weren't a lot of projects happening. Now we've got multiple projects in cancer itself being actually implemented into the system. How do we handle that so we don't all turn up at the doorstep of a hospital at the same time trying to implement a program? So we avoid the fatigue that could perhaps be introduced into the system.
Look, this is a growing area, and we need all of those projects to be occurring because there's not going to be a single solution. There are going to be many solutions for many different audiences if we're really going to develop change as rapidly as possible. So we should be celebrating the fact that there are lots of projects coming through with particular solutions. One of our challenges, as with any new and developing area, is how do we take each of those the findings of each of those projects and adapt it to the right audience in the right time. It's a wonderful problem to have. It's a problem we didn't have 10 years ago, and that problem is only going to become more acute as more people move into this area. But I think it opens the door for really tailoring very carefully the intervention with that particular audience, be it an individual practitioner or a group of practitioners.
Thank you. You mentioned earlier perhaps de-implementation as the flip side of implementation, if you like. And I mean, would you like to comment on that? I mean, are there specific challenges with actually taking something out of practice that has proven not to be effective? It's perhaps easier maybe to change practice in a positive way than actually take out a sustained piece of practice.
There is a challenge with sustained practice, whether it's been in place for years or decades. Stopping something generally is going to take far longer, particularly for the laggards, than it is to implement something new that clearly has success and is an easy investment decision to make. So we've got a real challenge. I think the tools are going to be similar. It is going to be about understanding the beliefs and behaviours of individual practitioners and groups of practitioners and addressing those in a systematic way if we're going to see those sort of changes. We have seen early evidence of the ability to de-prescribe, for example, in pharmacological treatments. We know that it can happen, and we know that those changes can be sustained. The question again is, how do we scale? How do we scale that up to be a whole of systems approach? And I think that the challenge here is not about developing new knowledge in implementation science. The real challenge will be applying that and scaling it up to the full system, as it is with so many other areas where new knowledge is generated.
We've talked a number of times now about implementation being a new science. Would you have anything to say to a young researcher that might be considering moving into implementation science as a career? I began my career as a basic research scientist, for instance, before moving into implementation science. Do you have any comments on that?
As for all decisions around careers, you want to be where the hockey puck will be, not where it is. And implementation science has a huge and shiny future. There is an enormous amount of work to be done here in really understanding how we take practitioners on a lifelong journey of learning. If we can do that successfully, implementation science at the individual practitioner level will be successful. If we can do that for whole disciplines, for funders and for the community more broadly, in 3 or 4 decades' time, we will have achieved much of what implementation science has set out to do. There is a fantastic future for researchers and for implementation practitioners, given the tsunami of new knowledge that is coming through. How we get that into practice, how we inform policy, how we drive change to improve patient outcomes across our community is the opportunity that is available to that generation, this next generation of new researchers and practitioners.
Well, thanks very much for sharing your thoughts with us today, David.
Have a great day.